After 1 year, we got it. We were given a telex from our cultural attaché at London Sudanese embassy so that we should go immediately to Sudan and because you have two assignments. One assignment is to start the primary healthcare program in Sudan at that time, 1976. Are you okay? And then the other point also is two of you, we were four actually. Two of us, myself and the late Dr. Fatah Zain Abdin, because we were younger than the two others, to proceed to Juba to follow up on the outbreak of Ebola at that time. If you remember, 1976, we had the first Ebola, which is spilled over from Zaire, if you remember, okay? So that gave us a very good, anyway, opportunity to go out and see what's going on in the periphery, okay? Okay, but in this context, actually, in Maridi, we went to Juba, and then we found that the outbreak was confined with what we call the cordon sanitaire. There were two public officers here, one from Sudan, from the north, and one from the south. They could confine that epidemic to Maridi area only. It could not spill to Juba, with no other than these conventional, say, methods by cordon sanitaire, no one to go out or to come in, and so on. And no case ever was reported in Juba, which is just 100 miles away. And these are only two health inspectors. Could you imagine that? And during that incident, actually, we lost one of our very a doctor, which is Abdin Khairi, who succumbed to the disease at that time with the Ebola. Then when we were sent to the different parts of the Sudan, myself to South Darfur, Al-Fatah Zain Abdin, Katugli, and other to Red Sea, we all started the program of the primary health care, and the main person in that is the community health worker, okay? So I have like 10 slides, which I will go fast on that, okay? As you see, as of year 2000, a renewed interest in the community health worker program has been sparked by a sense of urgency in achieving the MDGs. And you know the MDGs 4, 5, and 6, which were year 2000, and by 2015 we could not achieve these goals, but now we have the sustainable goals, okay? And so in that context of the sustainable development goals, we think that from a growing base of evidence for the potential contributions of this community health workers program to the health status of populations, including green energy, we included this green energy, climate change, and deforestation. You know, at the community level, deforestation is a very fierce phenomenon. This revitalized interest also arose from a concomitant or a commitment to the translation of the health services within the 2024 and 2030. This is the expressed policy of the government or the Ministry of Health, okay? And actually, we're all aspiring that in implementing these strategies, we will result or find that we can attain expansion, extension of the services to the poorest segments of the population who are being left behind by the ongoing pandemic and the natural emergencies which we are now facing. The profile of the community health worker is that this is a diverse group of community level workers distinguishing between two levels. You have one level, which is a full-time worker. He's paid with formal pre-service training, and the other one is a volunteer with short-term training, part-time worker, as you said. And some notable names called health auxiliary, village midwife, community health worker, and most recently frontline health worker, and to a lesser extent, say like trained community level workers, okay? The task of the community health worker is, who is he? He's a male or female, age 18 and above, okay, with at least secondary education. In the past, when we started the program, it was just like, say, intermediate education, intermediate. But now it is secondary. And this person is selected from the community in which he resides, receives a minimum of 12 months training, and is on the government payroll. I'm not sure whether it is 9 now or 12, okay? Community health worker main tasks include improving access to and the equity of health care by providing promotive, preventative, and selected curative services with special attention to women and children in underserved rural areas, in the peripheral areas. While there have been many studies examining the overall impact of the community health worker, the Federal Ministry of Health and UNICEF are indulged, and this is actually what we are doing now. We are undertaking a study by which we map up the whole overall process of this community health worker. We analyze the extension and reintegration of the program within the universal health, all within the adopted universal health coverage. Here you have a matrix actually which can just show you how the resources and the health sector here and the community district, and it's just self-explanatory in a way. This term of reference of this study which we are now undertaking with my colleague here, Dr. Reem, and we have Ustaz Durriya also as a nutritionist, part of the group, and Dr. Shadul is actually under his supervision and guidance with Dr. Asmahan. So we are looking to doing the mapping, service delivery analysis, and community-based health interventions to strengthen the healthcare at hard-to-reach vulnerable states. The global perspective, which we can just say, well, globally, human resources, we know the meltdown and the underlying and the poor performance of the health systems to deliver effective evidence-based interventions for priority health problems. Hence, the involvement of the community health worker in the provision of primary health care has been experienced all over the world for decades. And there is evidence that can add significantly to the efforts of improving the health. Globally, different patterns of primary health care delivery systems have been operationalized for over many decades in Indochina, Thailand, Pakistan, everywhere you can find something like that. And in nearby Ethiopia also they have an extension program for that. In Russia they have what we call the Feldsher, which is the backbone of the service. In Siberian, this is what they call the tundra area, which is very far away from the urban areas. And also we have the highly acclaimed barefoot individual in China. Here, I just mentioned that in 1967, 76, 77, we started this process. And well, now we have limited mapping of underserved communities were identified at that time. And the program monitoring and supervision over the years showed that the system ran efficiently and ensured that these salaried community health workers performed in a satisfactory manner, acceptable to their communities who had, in many instances, built their units through community mobilization like a NAFIR and so on. This is just functioning guiding principles like community ownership, community participatory approaches and dialogue. You have equity and access, and this is particular effort will be made to reach marginalized communities and individuals with the poorest access to health care. Support, of course, could be remuneration also of the healthcare worker, and also the support from the communities, for peripheral health units, and the local health structures, what you call localities and so on. As for partnership, multi-sector partnership will be developed at national and local levels to maximize effectiveness and efficiency of the community health worker. And coordination, the Ministry of Health, as the central player, leader, and the driving force behind this initiative, will ensure functional coordination structures at all the levels. And the coordination will make it possible for effective interventions to be selected according to local needs to ensure maximum impact. And no duplication, which is part of the whole thing. As for implementation, all health programs at community level will be implemented through the community health workers in accordance with the basic essential health service package, which is PPEHS, Community Health Strategic and Implementation Plan. Integration. Services will be integrated by working within a common framework, messages, harmonized communication materials, and using the community health worker as the point of delivery and building on existing programs and activities. And here we talk about strengthening of the health system at the same time as improving health at community level. Efforts must be made to ensure the referral health care process, which can achieve acceptable standards. And the rational implementation, districts should implement quality life-saving interventions in a rational, stepwise manner. Interventions to be implemented should be based on sound scientific evidence to enhance effectiveness. Evaluations were done actually many times, I think, and the last one was by WHO, I think, somebody called Wali. They went to North Kordofan and to River Nile, and they came up with certain evaluations, findings, and they put also their recommendations on that. But in a nutshell, you can say as of 2000, the Federal Minister of Health has adopted the family health approach that was holistic in nature and led by three categories of health providers: family physicians, medical assistants, and community health workers, according to the availability as per geographic area. The aim of the family health approach was to strengthen the primary health care system by setting up family health team with holistic patient-centered approach. And there was a strong recognition in the Ministry of Health in the need to integrate the work of the programs. However, that meant overhauling of the whole system. The questionnaire we are undertaking very shortly, maybe in the coming few weeks, will be guided in a way that we have key informant interviews, gather data on the program performance, a health extension worker interview to quantify the overall contribution of the community to the community health worker, to all clinical and non-clinical activities, and are taken at the facility. In addition to salary, of course, employment and community satisfaction. Health professional interview also to collect data on the health cadres on the facility activities. And patient-client interview designed to capture info on affordability, education, satisfaction on exit from the health facility. This is for these clients who come to the facility. And focus group discussions, which will be part and parcel of the whole process. I think this is the last one. And thank you very much. But actually, I want to ask something about the job satisfaction in a way, or you talk about the diaspora, okay, diaspora. I remember when we got our degrees in 1976, Liverpool, 4 of us out of 9, the whole batch was 9, one from Iran, one from Pakistan, one from India and Nigeria. The 4 of us came back to Sudan immediately. No one stayed behind. No one. Although at the ceremony which we had, some people came from the health planners came from Glasgow, Manchester, I remember Birmingham, and bringing us the contract just to sign and stay. No one stayed. And this is actually because there was some sort of job satisfaction. And at that time, our salary was only 80 pounds, which may be like $340, okay? But imagine that for the whole month, you will not spend more than 10 pounds on your living and so on. So that's, pardon? No one stayed, of course, you know. But now you talk about diaspora. Some people, at that time, even those clinicians who were sent there, I remember many of them, okay? No one stayed behind. All of them came back because there were some sort of perception and the remuneration was enough or adequate, actually.
Thank you, Dr. Abdel Halim, for the nice presentation. We meant by this presentation to show you that when it comes to the HRH issues, the health system policies may contain, or actually usually contain, an HRH strategies. And this policy, which is expanding the primary healthcare services for the whole community to ensure the access to the basic services, the HRH strategy in that policy was to produce community health worker. So our part is how we develop, how we to establish that program, how to prepare the curricula, how to select the suitable candidate according to the map, how to prepare the trainers, and then to conduct the training itself to ensure the quality of the final graduates and the means of assessment, ensuring that they have the needed competencies and capacities to serve where they are expected to serve. So by this example, we just tried to share an experience of how the HRH strategies is fitting and serving the overall health policies. As you see here, we have just only one share, which is producing the cadre itself. But as Dr. Abdel Halim already mentioned, there are other components, which is where they are going to stay, to station, where they are going to expected to work. هيشتغلوا وين؟ الفاسيلتيز يعني الانفراستراكشرز الموفرة لهم. It's a responsibility of another sector, which is the locality level, if I may call it, under the umbrella of the state ministries of health. So this is where they are expected to work, to get their salaries. Are they going to be appointed only, contracted, or they were going to be given jobs? Okay, those are the other part of the pictures that are related to other bodies. But if we don't produce the needed cadre with the expected quality, all the other components will be affected. Again, if we produce the cadre with the expected needed package of competencies and qualities, but the other stakeholders, they didn't do their share, the ultimate result is that the policy is not going to work and the challenges is still going to be there. This is just an example. So by this exercise, I'm wishing that for Prof. Shadul and Prof. Abdel Halim to complete the exercise and to share. Yani you are invited again once you finished your exercise and you submitted your final report, and after the permission of the UNICEF and the people sponsoring this study, to come back and share the results so for us to learn how we can improve and how we can address the challenges and the gap in this strategy. So this is the motive behind having this presentation, just to show the link between the HRH strategies and the overall health system policies, and to show you like a live example of how collectively together we can support the health system and strengthening at the end of the day. So the floor is yours. If you have any questions, any comments, if you would love to share similar experiences that show this type of coordination and the linkage between the HRH strategies and the other sectors to serve a common goal. Yeah. شكرا دكتور عبد الحليم مرة ثانية.